Without further ado, first off this morning, we asked Harold Miller to come and lead our workforce panel. Last night at dinner, Harold begged me not to read his introduction. He said, just say, here's Harold. So I'm kind of doing that, Harold, but I'm going to say, here's Harold, but Harold is one of the thought leaders in the country dealing with the future of healthcare. And one of the things we know about healthcare, those of us in healthcare, is that it will change. It won't be the same as it is today, not in how we pay for healthcare or in how we deliver healthcare. And there are a few people in the country that are willing to get in there and really work at the vortex of that change and try to influence things to go in the direction that they believe is the right direction for the country. And Harold is one of those people. So he called me up a few months ago and said, are you sure you want me to lead off this panel on workforce? Because I'm really a provider payment person, reform. And I said, no, that's perfect. Provider payment reform is going to have all kinds of implications for our workforce planning. So as we change how we pay for healthcare, we change who delivers healthcare and in what kind of setting and what kind of care delivery happens, that's going to impact our thinking about workforce. So I think it's perfect to start off with his presentation, and I'll get out of his way and let him do that. So please welcome Harold Miller.
I live in Pittsburgh, and we've been wishing for about 18 years now that we could stay up at midnight in October to watch something. So congratulations to those of you who have a team that you can stay up till midnight in the end of October for. So I'm going to give you a bit of a whirlwind tour of what I think needs to be done to try to make health reform work, and I guess major theme conclusion from all this from my perspective is that you can't make it work from Washington. You have to make it work at the local level, which is where all of you are. And thought leaders are nice, but doers are what count. And so the doers in the room is essentially who I'm speaking to. This is actually, this whole issue of healthcare costs is going to be something that I think is finally the platform is fundamentally burning in some fashion, because the deficit problem at the national level actually is a healthcare cost problem. And so it's going to get dealt with. The question is, how is Washington going to deal with it? And if you think about the policy choices that Congress and the President have, the way it usually gets conceptualized is Medicare spending, which is the big driver of that, typical quantity times price equation. You can either cut services to seniors, or you can cut fees to providers. Guess which one they're going to pick? Hardly likely that they're going to do the first. And so if you look at the lists of things that the super committee is looking at right now, it's a question of which providers are going to get cut how much. Whether it's doctors or whether it is home health agencies or hospitals or nursing homes, et cetera. And you've seen this approach being used for many years now. So if you're physicians, for example, what you see is fairly flat physician payment increases over a long period of time, with this looming and accumulating sustainable growth rate now up to 30% cut, which nobody thinks is realistic, but nobody quite knows what to do about that as an alternative. And the typical approach in the past was that when Medicare and Medicaid made cuts like that, who took it on the chin but the private sector? So cost shifting ended up meaning that if you got cut by the feds, then private payers paid more. But that's no longer a feasible solution. A lot of people show percentage of GDP charts in terms of how much healthcare costs are. The one that I think is actually interesting and meaningful is this one, which shows that public expenditures in the U.S. actually, as a percentage of GDP, are basically what's the same as in other countries. What's dramatically different is the private sector. And that is making businesses in this country increasingly uncompetitive. Just in the course of a decade, the contributions that businesses and workers have been making to healthcare has increased dramatically. And if that chart isn't obvious enough that that's a big increase, that chart shows you the top lines are the rate of growth of health insurance premiums and workers' contributions to premiums versus the lower lines, which are workers' earnings and inflation. And if that's not obvious enough about what that does to the individual worker, there was a study that came out in Health Affairs in September that basically showed that healthcare costs have essentially completely eaten up all real wage increases that families have had over the past decade. So $1,910 more dollars in income for a typical family of four went to inflation, to health care, and left them with a grand total of $95 more in net new spending. So what we need is a way to reduce costs without rationing. But you can't do that from Washington. It's got to be done at the local level because that's where health care is delivered. Which is why discussions like this today are particularly important, because it's got to happen in Missouri and in the regions of Missouri. But the question is, can it be done, even at the local level? And I've been surprised at how many people around the country think that you can't do that. The only way that you're going to be able to reduce costs is to take something away from patients, and I don't buy that. I think that there are three major ways that you can reduce costs without rationing. One is by keeping people well. If people are well, they have no health care costs at all, or minimal health care costs. If they do get a health care condition, and particularly chronic disease, which is one of the major drivers of health care costs nationally and certainly in the Medicare population, to help them manage that condition in a way which reduces the frequency with which they are hospitalized. And if somebody does need to be hospitalized for chronic disease or otherwise, to reduce the infections, the complications, the readmissions that still happen at very high rates in this country. Now, the nice thing about thinking about the healthcare cost reduction challenge that way is that all of these things will reduce costs, but they are all also quality improvements. And I think that if we were telling the American people that what we're really trying to do is to help them stay well, help them avoid going to the hospital if they don't need to, and to make sure that they have a good outcome when they do go to the hospital, then most people would say, you know, that sounds pretty good to me if that's what you're really all about. So what I want to talk about today is what are the things that you have to have in the community to be able to actually realize that kind of vision. I'm going to talk about 4 different functions that you need. The number one problem, I think, frankly, is that people have no idea today what as actually the costs are and what the level of utilization is. Most physician practices don't know if they have high rates of preventable hospitalizations and complications. PCPs typically don't know how often their patients are going to the ER being hospitalized. And when I talk to doctors, they say, I don't even know what it is, the cost of these things that I'm referring my patients to. So the solution, I think, is that we've got to get information. Now, we have tons of data out there, tons and tons of data, but we don't have actually actionable information for people to use. So we need to analyze that data to give, and particularly physician practices, the ability to find opportunities for cost savings and quality improvement, and then give them real-time performance information feedback. Telling people what happened several years ago is largely useless, but that's typically what we end up doing today. So how's Missouri doing? Well, it's actually hard to know because, in fact, there is difficult to get good data. It's difficult to get timely data. So I'll give you some examples of what we do know, but it is old and it is limited. So and the only major source that we really have of comparative information right now is Medicare data, to be able to see what's happening with the Medicare population. So I'll tell you what we can find out from the Medicare population. What we know from the Medicare population from several years ago is that people in Missouri get more surgeries than people in 43 other states in America. What kind of surgeries are they getting? Well, it appears that there are worse hearts, backs, knees, and prostates in Missouri than most places in the country. For some reason, the hips are better here. I don't know what it is you do in Missouri that makes your hips better. And it's not even in all of Missouri that the hips are okay. Because if you look across Missouri and the different regions in Missouri, the folks who live around Columbia apparently have worse hips than the people who live in St. Louis. And these, by the way, these are based on where people live, not where they get their care. So this has nothing to do with which hospital you have in your region. It depends on what they're doing, what the different hospitals are doing to the people who live in that region. Going back up the value chain, you've also got the 12th highest rate of preventable hospital admissions in the U.S. So these are what are called ambulatory care-sensitive hospital conditions, things like chronic disease and other things that could be prevented through good primary care. So again, chronic disease patients in Missouri are getting admitted to the hospital more often, 10, 15% more often than patients in the rest of the U.S., but with variation. So for some reason, asthma patients, at least in 2007, were not going to the hospital as often here in Missouri as in the rest of the country. And if you look at the whole, I mean, that's just Medicare. Is this a broader problem? Well, you have the 16th highest use of the emergency room in the U.S. for the total population, so in terms of people going to the ER. So what that says to me is lots of opportunity in Missouri to be able to find ways to reduce costs. So the number one function I think that communities have to have is the ability to get data and to be able to analyze that data and tell people about it. Now, I use the term analysis here rather than measurement, and that's a key distinction, I think. There's a lot of effort going on around the country to develop new measures of quality. And measures are these things that are statistically validated and National Quality Forum endorsed and that people can put up on websites and compare doctors and hospitals to each other. That is a very high standard to have some kind of statistic that you can actually do that with. And it's one of the reasons why we don't have nearly enough measures. And when CMS comes up with its ACO regulations, it basically has to go and find the measures that exist and throw 65 or 33 of them into the pool and say, well, this is all we have, so this is what we're going to measure you on. What we really need more of, I think, right now is analysis, exploratory analysis, to actually be able to look at the data and help doctors and hospitals and others be able to figure out where these opportunities are and to capitalize on them. Maybe they will turn into publishable measures at some point, but we need to start simply looking for opportunities right now. Now that raises a question, if you actually find these opportunities, so who should be accountable? Now, for years and years, we have had this myth in America that somehow this is health plans, that health plans deliver health care. And for several years recently, there was this sense that somehow hospitals should be in charge of trying to deal with this. But if you actually look at the opportunities that I've talked about and say, well, who's really responsible? Who really can take accountability for this? It's doctors. Because who is it that helps patients stay well? Who is it that helps them manage their condition? Who is it that makes sure that patients actually pick the right provider and facility to go to? It's doctors, physicians, and specialists. But that number one workforce issue is that those physicians are going to need to have a whole new set of skills and relationships to be able to make this work. Physicians are going to need to understand how to actually prevent hospitalizations and unnecessary testing as opposed to doing those tests, which is what they're trained for. Primary care physicians and multiple specialists are going to need to learn to work together better to manage complex cases. As opposed to the kind of duplication, lack of coordination we have today. And physicians in hospitals are going to have to work together jointly to improve quality and reduce costs. What's that mean? So what does a physician or a physician practice need to be able to reduce the rate of hospitalizations and unnecessary testing? Well, I'll give you my list of 6 things. First of all, the doctor has to have time to be able to do good diagnosis and treatment planning and follow up with the patients, which they don't have typically today. Second is that they need to have resources to be able to help their patients, particularly those patients with chronic disease, get educated about their condition and get the right kind of self-management support. Now, often this is done through hiring a nurse care manager to be able to help them, but there's a variety of ways to do it. But those resources have to exist. Third is there has to be an ability to be proactive about patient care, not reactive. You can't do this if you simply wait for the patient to come to you, because it may well be that they don't end up coming to you. They end up going to the ER or the hospital. Often this is done through tools like patient registries, but the basic idea is being proactive. Fourth is that you have to figure out which patients to focus on. This doesn't work if you do the exact same thing for all patients. You've got to figure out which are the ones who really are at highest risk and be able to focus on them. There are tools like predictive modeling that can help with that, but they are not, the issue is basically targeting. Fifth is coordinated relationships with your specialists and hospitals. And finally is data, information. Back to the beginning, is you got to actually understand how you're doing, where the opportunities are for improving. Now, all of those skills and capabilities exist in every community in America today, but we have invested most of them in health plans and disease management vendors who end up doing them completely independently from physicians in most cases. So you've got disease management vendors calling up the patient, never talks to the doctor, may be doing something completely different than what the doctor is talking about. We have a lot of efforts to try to create medical homes now, and that is helping to create some of those capabilities. But we still have those higher level capabilities are not there. So fundamentally what we've got to be able to do is to build in some of these additional capabilities for physicians and physician practices. How to think about the return on investment so that if you hire a nurse care manager, how many hospitalizations do they have to be able to prevent to be able to basically pay back their salary? In what time frame are they going to get the return? Is it 10 years or is it 1 year? And how do you target? All of those capabilities together is really what makes a physician practice. This is not individual doctors having to do this, but this is being part of a practice or a system that really creates that ability to be an accountable care organization to be able to do this kind of thing. So that's number 2 on the list, is having more value-driven delivery systems to have those kinds of capabilities focused on accountability. But then if you're trying to do that, you've got to have data. So having that data in the community is critical to support this. And as soon as you try to do that, you run smack into the healthcare payment system. The way we pay for healthcare today is that doctors and hospitals actually lose money if they prevent infections and complications and readmissions. Doctors and hospitals lose money when patients don't go to the hospital as often. And nobody in healthcare makes any money at all today when the patient stays well, which is not exactly what you would call a prescription for supporting the kinds of changes that we want. So how do you fix that? You've got to have value-driven payment systems. What are they? Well, there's 2 basic big ideas in healthcare payment reform. One is the notion of an episode payment, which says that rather than paying for piecework, rather than paying doctors and every individual doctor and hospital separately for care, and every time you get an infection or a complication you get paid more, there's a single payment whenever you go for an acute procedure or go into the hospital or need some kind of care. No more payment whenever something goes wrong that you have to treat. It's the same concept that every other industry in America has today, which is having a warranty on their products or services. Now, that sounded like an insane idea in healthcare up until a few years ago, when the Geisinger health system in Pennsylvania started to do this. Said, we're going to have, they didn't call it a warranty, the New York Times called it a warranty, but basically single price. When you come into the hospital for a procedure, I can't quite tell what's going on. There are gremlins in the sound system. Single payment for a 90-day period, so everything pre-admission, both doctor and hospital together, post-acute care, and any related complications or readmissions. And they started this with cardiac bypass surgery, and they have been systematically expanding this now to other kinds of care, including things like maternity care and low back pain, which are not necessarily even require a hospitalization at all. And what they found was really dramatic improvements in quality. Not little itsy-bitsy, teensy-weensy statistically significant changes, but 20, 40, 60% reductions in complications, infections, and readmissions. Quickly, these are 18-month results. Didn't wait 10 years for this to happen. At a place that already had a reputation for being a high-quality provider. And it was because the payment change enabled them to reinvent the way they delivered care without having to worry about the fact that they were going to lose money by doing fewer of certain things. Now, the myth that has developed, though, is that you have to be a Geisinger health system. You have to be a big integrated delivery system with employed physicians to be able to do this kind of thing. But the earliest documented example in healthcare of anybody giving a warranty was a single doctor, Lansing, Michigan, orthopedic surgeon, shoulder and knee guy, who said, I'm going to give a 2-year warranty. Anything goes wrong, I'm going to fix it free of charge. And it's in the literature The health insurance company paid less, the doctor made more, and the hospital made more, because they were able to reinvent the way they delivered care to weed out all the unnecessary services, focus on quality without worrying about losing money as a result. So it can be done by individual physicians in small hospitals, not just by big systems. Now, to understand the warranty concept, you have to realize two key things. One is it's not an outcome guarantee. It is not guaranteeing that people will not get an infection or a complication. It's simply saying that if it happens, we will fix it at no extra charge. And most warranties, as you buy warranties today, are limited warranties. You say we can't fix everything, prevent everything. The other key thing to understand about a warranty, which is kind of surprising for people, is that the price of warranty care is likely to be higher than today. Now, this sounds counterintuitive because we're trying to save money in healthcare, right? And the answer you get from payers is, why would we pay more to get good quality care? Well, if you think about it, though, in every other industry, when you get a product with a warranty, you would expect to pay more for a product with a warranty than a product that didn't have a warranty, because you know that you're not then having to pay for all the repairs, et cetera, that might come along with that. So same thing in healthcare. A DRG payment to a hospital would have to have a higher payment rate than the equivalent non-warranty DRG, but the higher payment gets offset by fewer complications and outlier payments, et cetera. Let me give you an example. So I'll take a hypothetical $10,000 procedure, and for whatever you might want to imagine the hospital say. And today, they paid $10,000, but 5% of the time, the patient gets an infection. When the patient gets an infection, serious infection, costs $20,000 to treat it. So on average, Medicare or health plan or whoever is paying for this is actually paying $11,000 for this procedure. $10,000 when it goes well, and then an extra $20,000 5% of the time. So on average, it's $11,000. So if you were the hospital and you wanted to offer the same procedure with a warranty, how much would you charge? Well, the answer is you would charge $11,000. Because if you charge $11,000 but you don't charge any more when the infections occur, you're getting exactly the same amount of revenue that you are getting today. Why would we do it? Well, we would do it because all the incentives have now changed. Because now, if you could actually reduce the infection rate from 5% to 4%, your costs will go down because you don't have to treat those infections anymore, but your revenues stay the same. So you actually make more money by doing better quality. But we want to save a little bit of money in healthcare, right? So this provider could basically say now, how about I'll charge $10,800 for this procedure? And maybe a health plan will send me more patients because I am now the higher quality, lower cost provider. And the incentives continue, because if I can keep driving the infection rate down, I keep reducing my costs, but I don't reduce my revenues, so my profits go up. And in the end, what do you get? You get higher quality, you get lower costs, lower spending than you have today, and the provider is more profitable. Win, win, win. Now that's in contrast to the way Medicare and health plans have typically been approaching this, which is to say, we won't pay for the infections, which puts the provider in a loss situation immediately. Before they have figured out how to get rid of those infections, you're basically putting them into a loss situation. They're digging themselves back out of a hole, trying to figure out how to reduce infections rather than being able to win. So being able to have provider-driven pricing based on this kind of payment model actually enables them to win both financially and from a quality perspective all along the way. Episode payment has a lot of opportunity. The one big disadvantage of the episode payment model is it doesn't do anything to prevent unnecessary episodes. And particularly if you're talking about those chronic disease patients, the idea is not that you simply want them every time they go to the hospital to have a more efficient, better outcome. You actually want them to go to the hospital less often. And you want to have fewer unnecessary surgeries. So what do you do about that? Well, second big idea in healthcare payment reform is what I like to call comprehensive care payment. Single payment for a patient's conditions or conditions to manage those conditions regardless of how often they go to the hospital. A lot of people like to call this global payment. I don't like the term global payment because I think the patients are going to think we're sending them off to India or Thailand to be able to get their surgery. The idea is it's a single payment for comprehensive care of the patient's conditions. And we know, in fact, that we can dramatically reduce the rate of hospitalization. Study after study after study has shown huge reductions in hospital admissions and ER visits and readmissions Again, not little small things, but 20, 40, 60% by doing very simple things. By having a nurse provide patient education and self-management support for chronic disease patients, doing telemonitoring to be able to identify early whenever they're having a problem. Why don't we do this? Because we don't pay for this. This is my picture of the way we pay for healthcare today. We pay doctors for office visits. We don't pay them to answer the telephone when a patient calls. We don't pay them to hire a nurse to work with the patients. But we pay every time the patient shows up at the ER, every time they get a test, and every time they show up in the hospital. So the basic idea of the comprehensive care payment is to give both flexibility and accountability. If it makes sense to answer the phone, do an email, do telemonitoring, hire a nurse care manager, do it, if it will in fact be able to reduce the number of hospital stays and ER visits and lab work and imaging. Don't let a health plan manage that. Provider themselves has the flexibility and accountability to be able to do that. This is what Blue Cross Blue Shield of Massachusetts is doing through what they call their alternative quality contract. Single payment for all the costs of care for a population of patients. It gets adjusted up or down based on how sick the patients are. So this is not a traditional capitation system where basically you get hurt financially if you take on sicker patients. This doesn't pass on the insurance risk to the provider. And there are quality bonuses. So you actually are rewarded if you do a better job on the quality side. And an important feature of this is it's a 5-year contract. Not this 1-year deal that it typically happens in healthcare. 5 years so that you can actually reap the benefits of making investments in things like prevention and better technology to be able to do this. And in this particular case, Blue Cross is giving very strong analytic support to the physicians and hospitals to understand where the opportunities are. And they've had very broad participation in this, including not just big systems, but they have one primary care independent practice association with 72 docs that is managing under this system. And they've had very positive first-year results published in New England Journal of Medicine and Health Affairs showing that they were able to improve quality and reduce utilization through this. To do this, different payment systems, you've got to be able to assure quality because the patients are going to inherently be nervous that if doctors and hospitals are suddenly thinking about cost, that they're going to stint on care. And of course, we know the fee-for-service system is perfect, really aligned with quality. So any effort that we make to move away from it is going to cause a concern there, right? But what you really want to have is some kind of good quality measurement and incentives associated with that. We are much farther ahead today than we were 20 years ago back in the 1990s with quality measurement. We are far from where we need to be, but I think that's something that develops over time. One of the questions, though, becomes, who measures quality? Where does it get measured? And I don't think that measuring it in Washington is the right thing to do. I think it needs to be measured at the community level. And a growing number of communities around the country, including Kansas City, are now measuring quality of care so to be able to help assure patients and help them select who are the highest quality providers. So measurement supports payment and vice versa. You have to have both to be able to move forward. And the payment systems and the delivery systems have to co-evolve because you can't pay differently if you don't have providers who are able to accept it. And you can't change the way care is being delivered unless you have a payment system that supports that. How do the care systems need to evolve? Well, I already talked about how physician practices are going to need to change and the kind of capabilities that they need. How will hospitals have to change? Well, it doesn't exactly take a genius to think that if you look at my chart and say we're trying to keep people well, keep them out of the hospital, and reduce potentially avoidable complications in the hospital, that's going to mean fewer patients, fewer patient revenues, fewer patient days in the hospital. A little frightening thought for hospitals. And particularly because hospital costs are not proportional to utilization. So, simple hypothetical here, if a hospital has a 20% reduction in its volume, let's suppose we're really successful in keeping all those chronic disease patients out and we reduce unnecessary surgeries, the hospital's costs may only go down by, say, 7%. But the payers will happily pay the hospital 20% less for having 20% fewer patients in the hospital. And you don't exactly need an advanced degree in hospital finance to understand what that means. 20% less revenues with 7% lower costs, bad financial deal for the hospital. But what's actually happening is at that point, if the payers were paying the right amount at the beginning, which they may not have been, but if they were paying the right amount at the beginning, they're no longer paying the right amount. because now you end up having higher unit costs with lower volume, even though spending is lower. So there's going to need to be a renegotiation about prices for care. And you can still have a win-win, because the payers can still save money over what they're doing today, but to do it in a way that doesn't send the hospital into bankruptcy. And I think this is going to be a big issue for communities around the country, is to help find the right glide path for hospitals, because hospitals have made huge investments, capital investments in facilities and equipment under the old payment system that are not going to disappear overnight. And we're going to help them transition. Now, if you're a hospital that's bulging at the seams, you may be happy to have fewer of these chronic disease patients. But particularly for small community hospitals, this is going to be a big problem. The Geisinger Health System in Pennsylvania has been so successful, for example, with its medical home initiative, that a number of the community hospitals in their geographic area have seen their admissions go down by 50%. Real challenge for a hospital to be able to keep up with. Now, in the long run, you can get restructuring, but not in the short run. So there's going to have to be some new kinds of discussions between hospitals and payers, and a better understanding of hospital costs to understand exactly what those alternatives are. So what's all this mean for the healthcare workforce? Now, if you were thinking of just what I'm talking about in terms of hospitals, you might be a little bit nervous if you work for a hospital. Because if hospitals are suddenly going to be reducing costs and reducing volume, what's that mean to me? You might be particularly nervous in Missouri, because Missouri has more hospital employees per capita than the U.S. average. Doctors may be a little bit less worried, because Missouri actually has fewer physicians per capita than the average. But even if that were not true, guess where most of the people who work in health, who they are? They're not doctors. They're everybody else. So, for example, this shows total physicians in the markets in Missouri per capita versus hospital employees. Hospital employees, dramatically larger population. So you might be really nervous about what's this going to mean for hospital employment. But an interesting thing, if you go back and you look over the past 20 years, so this is national hospital expenditures. Hospital expenditures have gone up dramatically in the past 20 years, but hospital employment has not. Now, that doesn't mean that all of those hospital employees are suddenly making $175,000 a year on average. What it means is that the biggest driver in hospital costs is actually not the employees, it's all the other stuff. All the devices, all the drugs, all the equipment that's being used, et cetera, in hospitals. And that creates an opportunity. And it particularly creates an opportunity in Missouri, because you actually have here one of the lowest percentages of hospital expenditures on personnel of any place in the country. So that chart shows the blue bar is the U.S. average, and the U.S. average is at about just a little over 50% of hospital expenditures go to personnel, salary and benefits. Missouri is only around 47%, and there are parts of Missouri that are actually even lower than that, around 43%. In contrast, for example, Minnesota, 55% of hospital expenditures go to personnel. So that's an opportunity, because that says that there may be a whole lot of costs that might be able to be controlled that don't necessarily affect people. And here's the Minnesota-Missouri comparison. Now, Missouri is a bigger state than Minnesota, so you would expect there to be somewhat higher expenditures dollar for dollar. But the interesting thing is that personnel costs in hospitals in Missouri, this is 2008, were only $500 million more. But everything else was $3 billion more. So when you think about it, well, is it possible for Missouri hospitals to reduce costs without cutting staff? Highly possible. How? Got to be figured out by the folks who work in them. So what I think successful healthcare reform is going to mean for the healthcare workforce is, first of all, there's going to inherently be a higher percentage of total healthcare jobs that are outside of hospitals. Because if we're trying to keep people well, keep them out of the hospital, we're going to have more of that care operating in the community. It's not that simply they somehow aren't in hospitals and they don't need any care. So, for example, those nurse care managers that I talked about that help keep the chronic disease patients out of the hospital, we're going to need more nurse care managers in the community. We're going to need people visiting people in the home rather than seeing them in the hospital. There's going to need to be greater capacity in primary care. because primary care is at the core of all this. So we're going to need more primary care physicians versus specialists. We're going to need more nurse practitioners and nurse care managers to be able to support them. And I think overall, there's going to need to be higher expectations for all healthcare workers to figure out how to deliver higher quality and lower cost care, helping the patient stay well, helping them get out of the hospital, and when they are in the hospital, eliminating the infections and complications and figuring out how to reduce the cost and the utilization of all those other things that are driving hospital costs and healthcare costs in general. So what's left? Well, you might think I'm going to put healthcare workforce in box number 4. I'm not, because there's one big piece that we have not talked about at all so far, and that's the patient. It takes 2 to tango in healthcare, and we've talked all about what you're going to do with the doctors and the hospitals, but what about the patient? Big issue, for example, is benefit design. So when I talk about payment reform, that's all about how you give the provider, the doctors, the hospitals, the home health agencies, the ability and the incentives to keep patients well, to avoid unnecessary services, to deliver them efficiently, and to coordinate with other people. But the patients also got to have the ability and the incentives to improve their health, to take their meds, to enable somebody to coordinate their care and to pick the highest value providers. And I think one of the biggest single examples of that is we have a almost complete disconnect in this country today between pharmacy benefits and medical benefits. So if you take, for example, those chronic disease patients that I've been talking about, what is the way that you help them manage their condition and stay out of the hospital? It's having them get the right chronic disease maintenance medications and to take them. And if they can't afford to take those medications because the co-payments are too high, because they're in the Medicare donut hole, what's the doctor supposed to do? What's the nurse care manager supposed to do? That's on the insurance benefit design. So things like that have got to get fixed. And a lot of people talk about how do we need to penalize the patients for not doing the right thing. I think in many cases the lack of adherence is because we haven't created a structure that enables the patients to adhere properly. Both of those things are controlled by the payer. The payer health plan controls both payment system and benefit design. But standing behind them are the purchasers, the employers, the state, who actually are the ones that choose the health plans. And if you're a self-insured employer, that sets some of those design questions. So getting the employers in the community involved in this is critical because they're the ones that are going to be making a lot of the key decisions behind this and making sure that these payment systems and benefit designs change. And what is one of their biggest resistances to that is whether their employees are supportive. So that comes back to the very beginning. What are we doing this for? And we've got to be able to convince the patients, the citizens of the community, that what we are about is trying to actually help them, to deliver them better quality care as well as be able to reduce the cost of it. So that is the number 4 box, and it's at the top because I think getting consumer support and engagement in this, having them educated, having measures of their experience in healthcare, not just these formal quality and cost measures, being able to get the patients to actually participate in the delivery of care and have benefit designs that support that are going to be critical. Now, when you look at this then, lots of stuff has to happen. And I think one of the biggest problems we have today in healthcare reform is people are looking for some silver bullet, that there's somehow one thing that will make the difference. If we just change payment, everything else will magically change. Or that if we give the right incentives to patients, that everything is going to magically change. Or if we simply post on a website different quality measures, that people are going to magically change. Not going to happen, because all of those things actually have to happen. We have built a system in a particular way that has gotten embedded for decades now. And it's going to take a while to change, and all these pieces that have been built to support that have to change. And all of that can't proceed in silos, because you've got to be able to change payment and delivery simultaneously to be able to make this work. So the question is, who can actually connect and coordinate all of that? How many people vote for the federal government? You got to really do that at the community level. And that's really the notion of what we call today a regional health improvement collaborative. An entity, a nonprofit entity, doesn't pay for care, doesn't deliver care, but helps to bring everybody together and to help make sure that these critical functions are all getting done and getting done in a coordinated way. And the critical piece is creating a table where all the different stakeholders can come together where the purchasers, the payers, the providers, and the consumers can all come together, because everybody's going to have to change. And they're going to have to figure out how to do that from a community perspective, where everybody may have to give a little bit. I think there are win-win-win opportunities, but they've got to figure out what those are. And we've had a growing number of these around the country, and you are fortunate enough to have two of them in Missouri, the Kansas City Quality Improvement Consortium and the Midwest Health Initiative, which is just in the process of getting underway and starting to do some measurement. But they provide opportunities in at least two of the markets in the state to be able to bring all the stakeholders together to be able to move this forward. So my message to you is, don't wait for Washington. There's this sense that somehow we have to figure out, wait and see what Medicare comes up with or what Congress comes up with. The truth is, there is no one-size-fits-all solution or implementation path on this. I think every state or community is going to be different. They are different today in terms of their structures. And the best thing that the federal government can do is to support local strategies. But it starts by actually educating all the stakeholders in the community, all the doctors, all the hospitals, all the employers, and the consumers about the need for changes in payment and delivery and benefit designs, and then bring them together to design win-win-win approaches. And in a number of communities around the country, what we have done is had all-day summits, not PowerPoint presentations, but people actually going into rooms and working multi-stakeholder basis to design what they think the new payment and benefit designs should be. And they do come out with consensus in the course of one day about what needs to be done. Lots of work on the implementation side, but at least having something that everybody agrees is where we want to be able to get to is a critically important part of that. And then go and get federal and state support to be able to support that. Bottoms-up approach to have the communities decide what they want and then get others to play rather than wait to be told by somebody else. And then measure your progress. It's going to take time, and there are going to inevitably be challenges. Things are not going to work the way everybody would hope. And you don't want everybody going back into their own corner and say it failed because it was their fault. You got to have a mechanism for everybody to come together and say, you know, we got to solve this problem. Let's get back to the table and figure out how to overcome that in a way that we will all benefit from. So that is my 78 RPM tour of payment reform, benefit design, delivery reform, et cetera. Lots more stuff on our website that you can read about these options in more detail. I would strongly encourage you, if you can, to become educated about all of these things. And figure out how to put them in place in your community. And with that, I will stop and take questions, challenges, disagreements, violent or otherwise. Yes, ma'am.
Hi. Yeah, I'm a family practitioner, and I'm now in a very rural area. I had been in the Columbia area, and I was saying there it was very easy to work with patients. They were very committed on wanting to be healthy, and it was just wonderful. Well, now I'm in a very rural area with a lot of Medicaid and a lot of people that are uneducated, and there's a real problem with them caring about their health. You know, we're saying we should grade the doctors on their A1Cs and things. We have patients that they could care less. They don't come back for their appointments. They weigh 400 pounds. They smoke. In other words, they're not at all invested in their health care. And what will happen, I think, is if we do this and give the doctors marks, they're going to drop these patients that don't comply, and they're just going to drop them. And what I'm seeing in this rural area, there's a large percentage of patients that fit that category.
Mm-hmm. Well, that's why I said I think we should be a little less obsessed with giving the doctors marks on posted quality measures and more on trying to give them the flexibility and accountability to achieve what they can. I also think that the kind of things that you're talking about are not going to get fixed overnight. They're going to take a long time to be able to address, and we shouldn't just ignore the problem on that basis, but we shouldn't be expecting that somehow it's all going to be solved in the course of the next year. Some of that is going to go back to the educational system and educating people at early ages about how to do that. So it's going to take some time. But I also think that in many cases, particularly physicians, sometimes get understandably very focused on the worst cases that they deal with. in terms of the most rabidly non-adherent patients that they have, as opposed to the ones that would be willing to change with some better support. And so I would argue that we should be trying, to focus on some of the ones who simply aren't adhering because they can't afford their meds, or because we have not created a system that is actually accessible to them. And to think about, so if the patient isn't coming into the doctor's office, is it because the doctor's office isn't open at the times that the patient can come? Is it because we're not available by phone if they call, et cetera? And I think this is particularly a problem for lower income patients, for Medicaid patients, et cetera. We have a healthcare system today that in many ways is designed for middle class people on salaries. So that when I go to the PCP and I have to basically take the day off of work because I'm going to go and sit in the office for 3 hours, and then they send me off for tests and 3 specialty consults, all of which will be on other days, which will also require me to take a big time off of work. And if I'm trying to figure out how to pay the bills, taking all that time off of work and losing money is not exactly a good trade-off for me. And that's where the flexibility in the payment system comes into play, because if we think that we could design something better that would actually reduce the likelihood that they're going to show up at expensive ERs and hospitals, then we may be able to deliver healthcare in a way that actually works better for the patient. And I think in rural areas, for example, you've been one of the leaders here in doing telemedicine, is thinking about whether there are more efficient ways to be able to reach people than typical approaches. But that is something that typically doesn't get paid for today. And the reason why it doesn't get paid for is that the fear is that that's simply going to be a new benefit and everybody's going to get it whether they need it or not, which is why doctors have to be, I think, are central to this, to be able to figure out what will actually make sense and who really needs that, where it will make a difference. Other questions? Yes, ma'am. In the green.
Just to follow up on the question over here, public health systems have been working so hard against enormous disadvantages to try and address some of the issues that she brought up, particularly like rural health. It's easy to assume the patients don't care, but there's this whole socio-cultural element out there that influences how people behave towards their own health and towards the healthcare system. And public health systems have, launched focus groups and learned a lot about the complexities of our rural patients. And so I was wondering what your thoughts are when you bring together a community to discuss, improving preventable hospitalizations. Do you have public health people at the table? And what role do you see for our public health workforce in all of this?
The answer to the first is yes, they often are, and they certainly should be. I think that it's a key role, but again, it also gets to the issue of, are we talking short-term or long-term? Because there's a longer-term element to that. There are folks in Minnesota that have been talking about the notion that in addition to accountable care organizations, which are healthcare providers, that we should be thinking about how to create accountable care communities and try to think about sort of how do you get the entire community engaged in some of those things. And it raises some interesting questions about accountability, too, because who's accountable? And is there a way, if we're trying to reduce obesity in the community, not just have some generic goal that says, we want to reduce obesity, but so what exactly should the schools be doing? And what exactly can each of the employers be doing? And what can we be doing in terms of preventive services to reach the people who need the most? Right now, unfortunately, there are not typically any rewards for doing better. We were talking in a meeting yesterday, there are a number of employers that are starting now to think about making their business location decisions based on whether the community is, in fact, doing things to keep people healthier and to be able to reduce costs. And I think that in the long run, we need to start thinking about this whole area as being an economic development initiative, not a health initiative. Health is one of the mechanisms to be able to do that. But if fundamentally what people need is jobs and income, and if you can create a healthcare and a community structure that will actually deliver better quality and lower costs, that can become a magnet for both people and jobs to come to the community. And I think that then really creates the business case for public health, because public health hasn't had a business case for it. You kind of have to believe in health and then say, how much money am I going to put into public health, as opposed to this is a critical investment in the community. Okay, the lady in gray or brown here? Yeah.
My question has to do, and pardon my voice, my question has to do with...
You should see your PCP.
He'd just tell me to go home and go to bed. So.
He'd say, go to the ER. Right.
My question has to do with these regional health improvement collaboratives,
yeah.
And I see them as having great potential, but I also see that in a state like ours, and I assume elsewhere in the U.S., there are very variable stages of readiness and or local leadership available to head in that direction. So my question is, what are there policy incentives or financial incentives that could help promote the development of that kind of system? And if so, are any of them present in our current discussion about healthcare reform?
Well, I think the strongest incentive that can exist is what I just said a minute ago, which is that if communities start to see that this is critical to their future, to be able to manage healthcare costs, to be able to deliver high-quality healthcare, and if they then understand, which a lot of people don't, sort of all the moving parts of this puzzle that I just talked about, then that's really what creates the case. Because today, if you think that this is just something that hospitals or doctors can do on their own, or you give them a little bit of P for P bonus and somehow that's going to change everything, there isn't a strong case for trying to create that process. But if you realize that you've got to have a lot of different things change, and that you have to have everybody at the table to be able to do it, work on it jointly, that's what creates the case. Now, the collaboratives that do exist around the country struggle mightily to find the funding to be able to support themselves for this, because you want to have flexible funding to do that. I mean, some of them, KKIC in Kansas City, for example, exists at the moment because of support from the Robert Wood Johnson Foundation that's funding 16 communities around the country, but we need a whole lot more than 16 communities, and that program is supposed to end in a couple years. So I think fundamentally the communities themselves have to recognize that this is important to them. And if the businesses see that this is actually has the ability to reduce their costs, and if the doctors and hospitals see that this actually has the ability to be able to enable them to deliver better care at a lower cost without forcing them out of business, then that creates the business case for creating the mechanism for being able to support that. But it does require local leadership. And somebody really, if you're starting something from scratch, leaders in the community have to get together and say, we got to do this, and we have to have a mechanism to be able to support us. Other questions? I'm going to let Karen watch the time and shut me down when, okay?
I guess help me summarize who connects the dots for the community. Because it's economic development. I don't really see it as a healthcare issue, but it's as much as GNP and debt ceiling and how the economy grows. It's all interconnected. So what do we do to help people connect the dots?
Well, you start with more education. I mean, forums like this where you bring people in the community together to try to understand what the opportunity is and what the solutions are. And then it requires some leadership in the community. It doesn't sort of, spontaneously appear. Somebody has to say, I care enough about this that I'm going to call up 3 or 4 of my colleagues. If I'm a business, I'm going to call the local health system, or if it's physicians, they're going to call up, the employers in the community. The real magic that I have seen happening around the country, frankly, is when the businesses in the community start talking directly to the doctors in the hospitals, rather than the way they do today is talking to them only through health plans, which is a little bit like having 2 tin cans connected by a string, that has a big slice in the middle, because you don't really get very accurate messages communicated that way. And when the businesses in the community actually start talking to doctors and hospitals and try to understand that there actually may be a way to make healthcare work in a way that's more like every other industry. In Rockford, Illinois, not too far away from here, north of Chicago, the employer group there is actually trying to move to this model, and they're focusing on this notion of potentially avoidable complications. And they said, this has suddenly given us a language with which we can now talk to the providers in the community. And the employers are now seeing the health systems as being suppliers to them. And every employer understands the notion of defect rates, and that they're basically buying a product, that they want a high-quality product. And when hospitals and doctors come to them and start talking about what they're trying to do to reduce their defect rate, their infections and complications and preventable hospitalizations, they can suddenly understand how to talk about that. And most employers understand the fact that if they're trying to work with a supplier to improve quality, that doesn't necessarily happen overnight. That you need to give them the time and the right support to be able to get there, but there has to be a commitment from the supplier that they actually are going to get there. So I think it's understanding better what the alternatives are. You're fiddling with the volume, aren't you? And being able to get everybody together. Other questions? Where'd Karen go? How long do we have? Okay. Other questions? Yes, ma'am, in the back. The man with the microphone is handing you a microphone there.
Well, thank you for the excellent presentation. I'm Jyotsna Reddy. I finished internal medicine residency this year, and I've joined MPH. I was particularly very interested in the evaluative research as the step 1 for the regional health collaborative that you mentioned, that there's more scope to analyze the data for the quality and cost effectiveness assessment. My question is, do you at your center, have you developed any models for such analysis, and any group that is willing to initiate such evaluative research? Would you be able to extend technical versus other support to such teams wanting to develop such models and develop the instruments for such analysis?
Well, this is actually an area that is just now being developed, because very few people do this today. Health plans claim to do it, health plans in the room, but are generally very poor at it. There's an organization called the Healthcare Incentives Improvement Institute, which has a payment model called Prometheus. But what they have actually gotten the most traction with is an analytical methodology that they have called PACS, potentially avoidable complications. I didn't include one. I often show one of the slides I didn't have with me today. But what they will do, if they can get the data, and this requires the health plans in the community to actually provide their claims data to them, is to actually run calculations across the whole range of the patient population and look at individual conditions and find out what percentage of the patients and what percentage of the dollars are going to things that they call potentially avoidable complications. And there's a very well-defined definition of potentially avoidable complications. So for the chronic disease patients, it's hospitalizations, because that's basically if you have a chronic disease and you are hospitalized for an exacerbation of the chronic disease, that's something that you want to avoid. If you're going in for knee surgery, the complication is an infection that you get during the course of that. Or some other complication of surgery. And so they basically measure that and provide the community an opportunity to look at it and say, so how much dollars are going to things that we could potentially avoid? and where should we concentrate our efforts first. Now, what they found through that methodology is that, in fact, the biggest chunk of the dollars is really in those chronic disease admissions. But it varies dramatically from community to community. Now, that methodology is limited in the sense that it actually doesn't do anything to look at the appropriateness of utilization. So it doesn't look at whether the knee surgeries were all needed or whether the back surgeries were all needed and whether there were different ways of being able to treat that. But it's at least one window on it. And they will do that, and I can certainly hook you up with them to do that. But it's one of the things that the regional collaborators around the country are now starting to look at, is how to do that analysis. The single biggest impediment that exists today to doing that analysis is actually getting the data. A lot of the health plans today are resisting turning over data to communities to be able to analyze it. Look in the Wall Street Journal yesterday morning and see an article by Anna Matthews, who wrote about the fact that this is a serious problem around the country, is that people who are trying to look at cost and utilization data cannot get the data from the health plans because they view it as a proprietary thing. And that's why you have to have the employers in the community and the providers talking to each other, because it's actually, in most cases, it's the employer's data. And they have to say, we want this data to go, and if the health plan is going to resist giving the data, then we're going to go switch health plans to be able to do that. So the first thing you've got to have is the data. And then the analytical, there are some analytical methodologies, and it's another one of those chicken and the egg things. The methodologies will develop as data is available to analyze, but right now the biggest problem is getting the data to analyze. And it's one of the biggest problems I think exists right today with the whole Medicare Accountable Care Organization effort is Medicare wants people to apply to be ACOs. They have no data. They have no data to understand what's actually happening with the Medicare population. And they've been promised that they will get some data if they apply, but again, it's sort of a chicken and egg. I'm going to apply first and then I'm going to get my data. Other questions over here? Yes, there's a microphone coming up behind you.
You spoke to the need to having more primary care providers, but in a climate where medical school debt is rising, I was wondering if you had any thoughts on how to increase the number of primary care providers.
Well, I think the single biggest thing we have to do is to make primary care a more attractive profession than it is today, given the way we pay doctors. So the prospect of getting on the primary care hamster wheel where you're getting paid barely for a 10 or 15-minute visit and you have to cram all those patients in the day simply to be able to get enough money to pay the staff and maybe your own salary is not a pleasant thing. And I think there was a physician who runs a independent practice association in Maine. They've started their own Medicare Advantage plan, and he says the goal is to have our doctors wake up in the morning not worrying about whether their schedule is full, but worrying about whether their patients are getting good quality care. I was in Cleveland a couple weeks ago. We had an all-day payment reform summit, and a family physician stood up at the beginning, and she said that she had decided to voluntarily cut her salary in order to hire a nurse because she realized that she could not, by herself, take care of her patients properly, and there was no way to pay for that nurse except to cut her own salary. Now, that is a screwed-up system. That is a screwed-up system. And we've got to fix that if we're going to ever be able to attract more people into primary care. It is not just the salary, it's the way people earn their money. And I think one of the biggest things, the group health cooperative in Puget Sound in Washington has got a lot of attention for a project they did to create medical homes. And it showed improved quality and reduced costs and all those wonderful things that we need to achieve. But I think the thing that ended up getting the most attention from a lot of people was that there were several primary care physicians there who had been planning to retire and decided not to because they said, this is finally creating medicine the way I really want to be able to take care of patients. And that's really what we need to be able to achieve, is something that makes primary care more attractive to people and enables them to practice good care for their patients. So I think that if we can do that, it's going to take time to be able to do that, we'll help to attract people in. But again, it's one of those things that doesn't happen overnight because we have built a system for many years that has discouraged that. And one more or not? One more. Anybody have a one more? Yes, sir, right here in the middle. Your microphone is coming from two different directions, potentially.
I'd like to address an area that I'm personally involved with, and that's in-home care. We see, and I'm from a rural area, Cape Girardeau, we see a huge demand down there for in-home care, and we provide that as a nonprofit. It seems like every time cuts are made, it's to that particular area. And of course, that's an area, if you look at the cost benefit of in-home care as opposed to institutional care or whatever, there's a huge difference. I'll make it kind of personal in that I see the hospitals in our area, and we're sort of a center down there for Southeast Missouri, spending millions and millions of dollars on beautiful scenery for the hospital, and the rooms are equivalent to any cruise I've ever been on in the hospitals.
Why would you want to stay home if you could go to a room like that, right?
And my point is that there seems to be an emphasis institutionally on recruitment, so to speak, and making the environment there more of a resort environment where, in fact, the biggest savings seems to be in home care.
Well, yes. The challenge, though, as with all of this, is that how do you ensure that when you are putting money into in-home care that it actually is reducing costs elsewhere? And that's the fear that everybody has, is that if we simply pay for more home health care, that we will just get more home health care, and we won't necessarily get it to the people who need it. There have been some recent examples, this is what tends to drive Medicare policy, of fraud and abuse in the home health industry, where people are sort of jacking that up. But I think that if you can end up doing this in a structure where there is accountability that says, okay, we're going to give somebody in-home care because we know that that will actually prevent some dollars somewhere else. I ran a project in Pittsburgh that was focused on reducing hospital readmissions. And it was, we focused on COPD patients. It was very successful. We had a 44% reduction in readmissions. And we did lots of different things, but the single biggest change we made was we hired nurse care managers to make home visits. Health plans wouldn't pay for it. We ended up fortunately had a local foundation that was willing to pay for it. But this gets back to the workforce challenge that I said up there somewhere, is that I made it an absolute criterion that those nurses had to do home visits. And that was a real deal stopper for the recruitment process. We had a whole lot of nurses that said, I'll work for you doing care management, but I'm not going to somebody's home. You know, I'll talk to them on the phone, you know, I want to work. And I think we have one of the other big workforce challenges that we have is I think we have a whole generation of RNs today that, you know, are used to working in an institutional environment or on phones and not actually going out to the home. But what I said to the nurses that we hired was, your job is to keep 13 people out of the hospital the next year, because that's what will pay your salary. And beyond that, you have complete flexibility. If a patient needs 5 home visits, make 5 home visits. If the patient doesn't need a home visit at all, don't make a home visit, because you can best judge what the patient needs and what's really going to have the impact. And I think that folks in home health care, in fact, are the most entrepreneurial people that exist in healthcare today, because they go into people's homes all by themselves and have to figure out how to solve the problem. But that's what we want to be able to create, is that kind of accountability that says when we do it, you know, it's going to be focused on the things that will make a difference. And Karen has the look on her face that says, that's it, bye. So thank you all. Appreciate the opportunity to be here.